Question 1. A 68-year-old male is found unresponsive on the floor after a witnessed fall. He has labored, shallow respirations. Which of the following is the absolute contraindication to using the head tilt/chin lift maneuver?
A.
Possible cardiac arrest.
B.
Snoring respirations.
C.
Suspected cervical spine injury.
D.
Absence of a pulse. Answer.
C.
Suspected cervical spine injury. This question tests the essential concept of airway management when spinal injury is possible, with the keyword absolute contraindication serving as the critical clue. The head tilt/chin lift maneuver is used to open the airway by moving the tongue away from the back of the throat, but it requires hyperextending the neck, which is dangerous if there is a neck injury. In trauma patients, the jaw thrust maneuver is the required technique because it opens the airway without moving the cervical spine. Always assume a spinal injury in an unresponsive trauma patient until proven otherwise, and prioritize protecting the spine while managing the arrow. Here's a helpful tip. Trauma equals jaw thrust. Medical equals head tilt/chin lift, unless the jaw thrust doesn't work. Question 2. Which of the following is typically the earliest sign of compensated early shock in an adult patient?
A.
Decreased blood pressure.
B.
Altered mental status.
C.
Tachycardia, increased heart rate.
D.
Pale, cool, and dry skin. Answer. C. Tachycardia, increased heart rate. This question addresses the vital concept of recognizing compensated shock, focusing on the critical keyword earliest to identify the body's first response. Compensated shock is when the body can still maintain a normal blood pressure despite significant blood loss or fluid depletion by activating the sympathetic nervous system. This activation causes the heart to beat faster, tachycardia, to circulate the remaining blood more quickly, and this heart rate increase is often the first measurable change. Pale, cool skin, and a decreased blood pressure are signs of later or decompensated shock, meaning the body's mechanisms are starting to fail. Remember that a fast heart rate is the body's way of desperately trying to keep up when it senses a volume problem. Question 3. You are treating a patient with a known history of type 1 diabetes mellitus who is conscious, but has an altered mental status and slurred speech. Her blood glucose reading is 58 milligrams per deciliter. What is the most appropriate initial intervention, assuming local protocol allows?
A.
Administer 1 aspirin, 81 mg or 324 milligrams.
B.
Administer oral glucose paste.
C.
Initiate rapid transport and administer 4D50.
D.
Administer supplemental oxygen via nasal cannula. Answer. B. Administer oral glucose paste. The concept tested here is the field management of symptomatic hypoglycemia, which is confirmed by the keyword altered mental status and the low blood glucose reading of 58 milligrams per deciliter. Hypoglycemia, a dangerously low blood sugar, must be treated immediately with glucose if the patient is conscious and able to manage their own airway to prevent aspiration. Oral glucose is the fastest way to raise the blood sugar in a conscious patient, which is often curative for their mental status. 4D50 is a paramedic-level intervention and only necessary if the patient is unable to swallow or is unresponsive. The critical takeaway is that a conscious patient with low blood sugar needs immediate oral glucose to correct the problem. Question 4. A 45-year-old male is severely bleeding from a deep laceration to his forearm after an industrial accident. He is unconscious and has no identifying family or friends present. Treatment is initiated immediately by the EMT. This is an example of what type of consent?
A.
Expressed consent.
B.
Implied consent.
C.
Informed consent.
D.
Minor consent. Answer. B. Implied consent. This question centers on the legal concept of implied consent in emergency medicine, with the keywords being unconscious, severe bleeding, and no family present. Implied consent assumes that an unresponsive patient would want life-saving treatment if they were able to make a decision for themselves. Express consent is when a conscious, competent adult explicitly agrees to treatment. The core principle is that when a life-threatening emergency exists and the patient cannot communicate, the EMT is legally and ethically obligated to intervene under the doctrine of implied consent. Always remember that implied consent is the permission we borrow from an unconscious, critically injured, or ill patient. Question 5. You are caring for a patient with massive external hemorrhage from a traumatic leg amputation. After applying direct pressure and a pressure dressing, the bleeding remains uncontrolled. What is the next most effective intervention?
A.
Apply a splint to the extremity.
B.
Elevate the extremity above the level of the heart.
C.
Apply a tourniquet proximal to the wound.
D.
Apply cold packs to the area. Answer: C. Apply a tourniquet proximal to the wound. This item tests the critical, life-saving skill of hemorrhage control, focusing on the keywords massive external hemorrhage and uncontrolled, which signal a direct threat to life. Current trauma protocols mandate that for severe, life-threatening extremity bleeding that does not stop with direct pressure, a commercial tourniquet must be applied immediately. Elevation and cold packs are ineffective or outdated for controlling massive arterial bleeding. Placing the tourniquet high and tight on the extremity, proximal to the injury, cuts off blood flow and is the definitive EMT intervention for this type of catastrophic bleeding. The most important lesson is that stopping life-threatening bleeding with a tourniquet takes precedence over everything else in extremity trauma. Question 6. During the primary assessment, which patient finding would classify the patient as a load-and-go priority requiring immediate rapid transport?
A.
Mild chest pain that resolves with rest.
B.
Open femur fracture with stable vital signs.
C.
Unresponsive patient with shallow, inadequate respirations.
D.
Isolated ankle sprain with no loss of consciousness. Answer: C. Unresponsive patient with shallow, inadequate respirations. This question covers the fundamental concept of patient prioritization during the primary assessment, where the critical clue is load and go, indicating a time-sensitive, life-threatening condition. A patient who is unresponsive and has inadequate respirations is experiencing immediate failure of the airway breathing circulation, ABC system. An open femur fracture is serious, but often can wait until treatment starts in the ambulance, while an ankle sprain or mild chest pain that resolves are generally not immediate threats to life. The goal of rapid transport is to get definitive care for patients who are unstable and whose conditions cannot be corrected in the field, like those with profound respiratory compromise. Remember that any issue severely affecting the ABCs instantly makes a patient a high-priority load and go. Question 7. The correct way to size an oropharyngeal airway, OPA, on an adult patient is to measure from the
A.
corner of the mouth to the angle of the jaw.
B.
Incisor teeth to the earlobe.
C.
Tip of the nose to the earlobe.
D.
Center of the chin to the suprasternal notch. Answer:
A.
Corner of the mouth to the angle of the jaw. This tests the basic yet essential skill of properly selecting an airway adjunct, focusing on the correct anatomical landmarks for the oropharyngeal airway, OPA. Proper sizing ensures the OPA extends from the corner of the patient's mouth to the angle of the jaw, which positions the distal tip correctly in the hypopharynx to lift the tongue away from the back of the throat. If the OPA is too small, it will not adequately lift the tongue, and if it is too large, it can push the epiglottis down and obstruct the airway further. Measuring from the corner of the mouth to the angle of the jaw ensures the device is the correct length to maintain an open airway without causing trauma or obstruction. Here is a simple way to remember. Measure the OPA from the mouth to the jaw. Question 8. A patient is experiencing a severe anaphylactic reaction and self-administers an epinephrine auto-injector. Epinephrine is effective because its primary action is to
A.
block histamine release and dilate blood vessels.
B.
Relax bronchial smooth muscle and constrict blood vessels.
C.
Decrease heart rate and lower blood pressure.
D.
Dilate coronary arteries and increase blood glucose. Answer. B. Relax bronchial smooth muscle and constrict blood vessels. The concept tested here is the mechanism of action for epinephrine, the life-saving medication for severe allergic reactions. Epinephrine acts as a potent vasoconstrictor, narrowing blood vessels to raise blood pressure and reverse shock, while simultaneously acting as a bronchodilator, relaxing airway muscles to open the constricted bronchioles. This dual action directly counteracts the life-threatening effects of anaphylaxis, shock, and respiratory distress. Understanding the action of epinephrine helps explain why it is the definitive treatment for anaphylaxis, as it treats both the airway swelling and the circulatory collapse. An easy way to think about it is that epinephrine is an emergency reset button that reverses the dangerous signs of a severe allergy. Question 9. When performing chest compressions on an infant under 1 year of age, what is the correct compression depth?
A.
At least 1 inch. 5 cm.
B.
Approximately 1/4 the depth of the chest.
C.
At least 2 inches 5 cm.
D.
Approximately 1/3 the depth of the chest. Answer. D. Approximately 1/3 the depth of the chest. This question tests the current American Heart Association (HA) standards for pediatric CPR, focusing on the correct depth for infant compressions. For an infant, the chest compression depth should be approximately 1/3 the depth of the chest, which translates to about 1.5 inches 4 cm. This depth is crucial because it is deep enough to circulate blood effectively, but not so deep as to cause internal injury to the smaller, more fragile infant anatomy. If the depth is too shallow, there will be inadequate perfusion, and if it is too deep, there is a risk of trauma. Remember, for both infants and children, the goal is 1/3 the depth of the chest. Question 10. A patient presents with a sudden onset of facial droop, slurred speech, and weakness on the left side of his body. Which component of the Cincinnati Pre-Hospital Stroke Scale is the EMT not testing?
A.
Facial droop.
B.
Arm drift.
C. Speech. D.
Grip strength. Answer. D. Grip strength. This concept examines the rapid assessment tools for stroke, specifically the widely used Cincinnati Pre-Hospital Stroke Scale, CPSS, which has 3 key components. The CPSS assesses facial droop, arm drift, and abnormal speech, slurred or absent, which are highly reliable indicators of a stroke. Grip strength is not a component of the CPSS, although a lack of grip strength would be a finding of motor weakness consistent with a stroke. Using a simple, 3-part scale like the CPSS allows EMTs to rapidly identify and flag a patient as a priority for a stroke center. Always know the 3 parts of the stroke scale, as they are the fastest way to recognize a potential brain attack. Question 11. In a multiple casualty incident, MCI, using the START triage system, a patient who is breathing spontaneously but whose respiratory rate is greater than 30 breaths per minute would be assigned which triage color?
A.
Black, deceased/expected D.
B.
Red, immediate.
C.
Yellow, delayed.
D.
Green, minor. Answer. B. Red, immediate. This question focuses on the crucial operational concept of START triage, a system for rapidly categorizing patients in an MCI, with the keyword respiratory rate greater than 30 breaths per minute being the defining factor. The START acronym uses 3 main assessments: respirations, perfusion, mental status, and any patient who fails the initial respiration assessment by breathing more than 30 times per minute is immediately classified as red, immediate. This rapid breathing rate indicates a severe problem requiring immediate intervention to survive. Remember the 30-2 can do mnemonic, a respiratory rate over 30, a capillary refill over 2 seconds, or an inability to follow simple commands all lead to a red tag. Question 12. A 30-year-old male was involved in a low-speed motor vehicle collision and is ambulating at the scene, reporting only neck stiffness. According to current evidence-based guidelines, the EMT should primarily focus on
A.
full spinal immobilization using a long backboard and head blocks.
B.
Applying a cervical collar and performing a careful, selective spinal assessment.
C.
Immediately applying manual stabilization and rapid transport without further assessment.
D.
Performing a complete neurological exam and administering pain medication. Answer. B. Applying a cervical collar and performing a careful, selective spinal assessment. This question addresses the 2025 relevant update on spinal care, emphasizing selective spinal immobilization over routine use of the long backboard for all trauma patients, especially with keywords like low speed and ambulating. Current guidelines promote selective spinal assessment using validated criteria, like the Nexus or Canadian C-spine rules, to determine the need for a cervical collar and a movement-restricted stretcher. Applying a cervical collar and assessing for pain, tenderness, or neurological deficit is appropriate because unnecessary full immobilization can cause patient harm or discomfort. The main takeaway is that routine use of a backboard for all trauma is out. Selective, careful assessment is in. Question 13. You are ventilating an intubated patient and note the end tidal carbon dioxide, EtCO2. Reading suddenly drops from 38 millimeters of mercury to 0 millimeters of mercury. What is the most likely cause of this sudden drop?
A.
Patient is hyperventilating. B. Massive pulmonary embolism.
C.
Esophageal intubation or tube displacement.
D.
Return of spontaneous circulation, ROSCI. Answer. C. Esophageal intubation or tube displacement. This question tests the advanced concept of capnography interpretation, where the keyword suddenly drops to 0 millimeters of mercury is the critical clue in an otherwise stable patient. End-tidal CO2, EtCO2, measures the carbon dioxide exhaled from the lungs, and a reading of 0 means no measurable CO2 is reaching the monitor, which is a hallmark sign of the endotracheal tube being displaced into the esophagus or completely disconnected. A massive pulmonary embolism causes a sharp decrease, but rarely to 0, and ROSC typically causes a sudden increase in EtCO2. In summary, a sudden drop to 0 on the EtCO2 monitor means the breathing tube is no longer in the lungs and requires immediate reevaluation and reintubation or bag valve mask ventilation. Question 14. For an adult in cardiac arrest, what is the correct range for chest compression rate, according to current American Heart Association guidelines?
A.
60 to 80 compressions per minute.
B.
80 to 100 compressions per minute.
C.
100 to 120 compressions per minute.
D.
120 to 140 compressions per minute. Answer. C. 100 to 120 compressions per minute. This foundational question addresses the most current standard for high-quality CPR, where the key concept is the minimum and maximum compression rate for effective circulation. Current guidelines state that compressions must be delivered at a rate of 100 to 120 beats per minute to maximize blood flow to the heart and brain. A rate slower than 100 does not perfuse the body effectively, and a rate faster than 120 compromises full chest recoil, which is necessary for the heart to refill. The quality of compressions is the most crucial factor in CPR, so maintaining this exact rate and depth is paramount to a positive outcome. Remember the rhythm. Push hard, push fast, 100 to 120 per minute. Question 15. Activated charcoal is commonly used in the management of certain poisonings. A major contraindication for the use of activated charcoal is
A.
Ingestion of an opioid overdose.
B.
Ingestion of a large quantity of acetaminophen.
C.
Altered mental status with inability to protect the airway.
D.
Ingestion of more than 1 hour prior to EMS arrival. Answer. C. Altered mental status with inability to protect the airway. The concept tested here involves the specific administration criteria and safety concerns for activated charcoal, with the keyword contraindication being the core clue.
Activated charcoal is an oral medication that can absorb certain toxins in the stomach, but it is contraindicated in patients with an altered mental status because of the high risk of aspiration into the lungs, which can cause severe lung damage. Even if the charcoal is indicated for the ingested substance, the patient must be conscious and able to swallow safely to receive it. Always prioritize airway protection over the administration of an oral medication. Question 16. What is the normal respiratory rate range for a resting, non-distressed adult?
A.
4 to 8 breaths per minute.
B.
8 to 12 breaths per minute.
C.
12 to 20 breaths per minute.
D.
20 to 28 breaths per minute. Answer: C. 12 to 20 breaths per minute. This question tests one of the most basic but essential components of vital sign assessment, the normal adult respiratory rate. A resting, non-distressed adult typically breathes between 12 and 20 times per minute, indicating a healthy exchange of oxygen and carbon dioxide. A rate below 12, bradypnea, or above 20, tachypnea, suggests a possible medical or traumatic problem that requires further investigation and intervention. Accurately counting the respiratory rate for 30 seconds and multiplying by 2 is a fundamental assessment skill that provides immediate insight into the patient's respiratory status. Always know your normal ranges, as they define the boundaries of health and illness. Question 17. The primary purpose of a completed patient care report, PCR, or run report is to
A.
Provide a legal document to justify EMS billing and payment.
B.
Create a comprehensive record for continuity of patient care.
C.
Document patient refusal of care for legal protection of the crew.
D.
Inform the media about the scene size-up and patient status. Answer: B. Create a comprehensive record for continuity of patient care. This concept focuses on the operational and ethical importance of documentation, and the keyword primary purpose directs attention to the core reason for the PCR. The run report serves as the official medical record of the patient's condition, the treatment rendered, and the response to that treatment, ensuring a smooth and safe transition of care to the receiving hospital staff. While the PCR does serve legal and billing functions, its most important role is medical, to communicate all relevant information for the patient's ongoing treatment. Good documentation is crucial because if you did not write it down legally and medically, it did not happen. Question 18. An adult male has full-thickness burns covering his entire right arm and his entire chest. Using the rule of nines, what percentage of his total body surface area, TBS, is burned?
A.
9%.
B.
18%.
C.
27%.
D.
36%. Answer: C. 27%. This question applies the assessment tool known as the rule of nines, which is a standardized method for estimating the severity of thermal burns in adults. In the rule of nines, the entire arm, anterior and posterior, is assigned 9% of the total body surface area, TBSA, and the entire chest, front of the torso, is assigned 9%. To calculate the TBSA, the EMT must add the percentages for the affected areas. 9% for the arm plus 9% for the chest plus 9% for the abdomen, which is the other half of the torso, totaling 27%. Accurate estimation of TBSA is vital for determining the appropriate amount of fluid resuscitation required in burn patients. Here's a tip. Remember that for an adult, the head is 9, each arm is 9, and the entire front torso is 18. Question 19. Anaphylactic shock is a type of distributive shock that is primarily caused by
A.
widespread vasodilation and increased capillary permeability.
B.
Failure of the cardiac pump to effectively push blood forward.
C.
Loss of blood volume due to external or internal hemorrhage.
D.
Obstruction of blood flow back to the heart. Answer:
A.
Widespread vasodilation and increased capillary permeability. This question tests the specific pathophysiology of anaphylactic shock, which is one of the 4 main types of shock, indicated by the keyword distributive.
In anaphylaxis, the body releases massive amounts of histamine and other chemicals that cause the blood vessels to relax, widespread vasodilation, and their walls to leak fluid, increased capillary permeability. This dual effect means that the blood volume is effectively lost from the circulation into the tissues, causing a rapid and severe drop in blood pressure. The other options describe cardiogenic shock, hypovolemic shock, and obstructive shock. An easy way to remember this is that in anaphylaxis, the plumbing suddenly widens and leaks, making the system distribute fluid incorrectly. Question 20. The most effective technique for a single rescuer using a bag valve mask BVM device to ensure an adequate seal is the
A.
two-hand technique with a jaw thrust maneuver,
B.
head tilt/chin lift with a circular grip on the mask,
C.
jaw thrust with the C-clamp technique,
D.
head tilt/chin lift with a C-clamp technique. Answer:
D.
head tilt/chin lift with a C-clamp technique. This question addresses the practical skill of positive pressure ventilation, focusing on the keywords single rescuer and most effective technique. The single rescuer must secure an airtight seal while simultaneously opening the airway, which is best achieved with the head tilt/chin lift maneuver combined with the C-clamp technique using one hand. In this technique, the thumb and index finger form the C to press the mask onto the face, while the remaining fingers form the E to lift the jaw and ensure the airway is open. The two-hand technique is superior for sealing but requires a second person for bagging, which does not fit the scenario. The main goal is to use the head tilt/chin lift and C-clamp to maintain a perfect seal and an open airway with one hand. Question 21. A common but non-specific sign of a severe infection, e.g., pneumonia or sepsis, in a geriatric patient is often
A.
high-grade fever and rigor,
B.
sharp localized pain,
C.
altered mental status or confusion,
D.
bradycardia, slow heart rate. Answer: C. altered mental status or confusion. This question highlights a critical concept in geriatric assessment: the atypical presentation of illness, especially infection, where the keyword nonspecific is a key indicator. Due to age-related changes, an elderly patient with a severe infection often does not exhibit the classic symptoms like a high fever or pronounced pain. Instead, the first or most prominent sign of a serious illness is frequently an acute change in their baseline mental status, such as new confusion or lethargy. Therefore, an EMT must have a high index of suspicion for serious illness whenever a geriatric patient presents with an altered mental status. Remember that an old patient who is suddenly confused or unresponsive may be critically ill from an infection. Question 22. A paramedic is performing transcutaneous pacing on a patient. Which dysrhythmia is a classic indication for pacing in a symptomatic patient?
A.
Ventricular fibrillation VF,
B.
asystole,
C.
symptomatic bradycardia,
D.
pulseless electrical activity P. Answer: C. symptomatic bradycardia. This paramedic level question tests the indications for transcutaneous pacing, TCP, a procedure used to externally stimulate the heart, and the keywords symptomatic patient and pacing are the crucial clues. Transcutaneous pacing is specifically indicated for patients experiencing a very slow heart rate, bradycardia, that is causing signs and symptoms of hypoperfusion, such as shock or altered mental status. Pacing is not effective for unorganized electrical activity like VF or for a complete lack of electrical activity like asystole. The goal of pacing is to increase the heart rate enough to relieve the patient's bradycardia-related symptoms, often by setting the rate to 60 to 80 beats per minute. Question 23. You are dispatched to a reported industrial accident involving spilled chemicals. Which action is the absolute first priority during your scene size-up?
A.
Determining the mechanism of injury.
B.
Establishing the number of patients.
C.
Ensuring the scene is safe and utilizing proper personal protective equipment, PPE.
D.
Calling for a medical helicopter. Answer: C. Ensuring the scene is safe and utilizing proper personal protective equipment, PPE. This question tests the foundational operational concept of scene size up, which must always begin with scene safety, indicated by the keyword first priority. EMS providers must always ensure the scene is safe for themselves, their crew, and the patient before attempting any patient care, especially when hazardous materials like spilled chemicals are involved. Approaching an unsafe scene, regardless of the patient's condition, risks turning one patient into two or more. The EMT's personal safety is paramount, as they cannot help the patient if they become injured. Here's the key takeaway. Never forget that scene safety, including appropriate PPE, always comes first. Question 24. A patient who has just experienced a generalized tonic-clonic seizure is often confused, drowsy, and maybe combative. This period is known as the
A.
tonic phase,
B.
clonic phase,
C.
postictal phase,
D.
aura phase. Answer: C. Postictal phase. This question focuses on the different stages of a seizure, specifically the state following the active seizing, which is the core concept being tested. The postictal phase is the recovery period immediately following the violent muscle contractions, tonic-clonic phases, and it is characterized by symptoms like drowsiness, severe confusion, and a gradual return to normal mental status. The duration of this phase can range from a few minutes to hours. The primary concern during this phase is airway management, as the patient may be unable to protect their airway due to the altered mental status. Remember that postictal means after the seizure, and the patient needs quiet reassurance and airway monitoring during this time. Question 25. Which set of signs is most indicative of a tension pneumothorax in a trauma patient?
A.
Bilateral clear lung sounds and high blood pressure.
B.
Jugular vein distension, JVD, hypotension and tracheal deviation, late sign.
C.
Flail segment and paradoxical motion of the chest.
D.
Subcutaneous emphysema and diminished lung sounds on the unaffected side. Answer: B. Jugular vein distension, JVD, hypotension and tracheal deviation, late sign. This question assesses the EMT's ability to recognize the life-threatening condition of a tension pneumothorax, where the key signs point to severely impaired circulation. A tension pneumothorax is a progressive buildup of air in the chest cavity that collapses the lung and pushes the heart and major blood vessels to the opposite side, leading to obstructive shock. The classic triad of signs are JVD, due to blocked venous return, hypotension due to shock, and diminished or absent lung sounds on the affected side, with tracheal deviation being a late and ominous sign. Recognizing these signs is crucial because the condition is immediately fatal without needle decompression. Question 26. A competent 72-year-old male with chest pain refuses transport and signs a refusal of care form. Which of the following is an essential step the EMT must take before accepting the refusal?
A.
Contact the patient's family doctor to obtain permission for refusal.
B.
Thoroughly document the patient's capacity and the risks of refusal.
C.
Immediately contact medical control to authorize the refusal.
D.
Physically restrain the patient to initiate mandatory treatment. Answer: B. Thoroughly document the patient's capacity and the risks of refusal. This question covers the critical legal and ethical concept of a patient's right to refuse care, focusing on the essential steps required to protect the patient and the provider. Before accepting a refusal, the EMT must ensure the patient is competent, mentally capable, and is fully informed of the specific risks and consequences of refusing treatment and transport. This thorough documentation serves as legal proof that the patient was informed and competent when they made the decision. The EMT must respect a competent patient's right to autonomy, which means they can refuse care, but it is the EMT's job to ensure that decision is an informed one. Question 27. You are attempting to insert a nasopharyngeal airway, NPA. A definite contraindication for its use is
A.
Patient is unconscious and unresponsive.
B.
Patient has a palpable fracture of the cribriform plate or severe facial trauma.
C.
Patient is breathing spontaneously and is able to maintain a patent arrow.
D.
Patient has a history of severe allergies to latex. Answer. B. Patient has a palpable fracture of the cribriform plate or severe facial trauma. This question addresses the safe application of the nasopharyngeal airway, NPA, and its specific contraindications, with the keyword palpable fracture being the vital clue. Severe facial or head trauma suggests a possible fracture to the cribriform plate, a thin bone near the nose, and inserting an NPA could inadvertently enter the cranial cavity, causing severe brain injury. While an OPA is contraindicated in a conscious patient with a gag reflex, the NPA is generally better tolerated, but a head injury with facial trauma makes the NPA too dangerous. Therefore, in the presence of severe midface trauma, the EMT should choose an alternative airway method, such as a BVM with a jaw thrust. Question 28. A 75-year-old male is complaining of sudden, severe, tearing pain in his lower back and abdomen. He is hypotensive and has a pulsatile mass in his abdomen. What is the most critical intervention?
A.
Rapidly administer oral pain medication.
B.
Gently palpate the abdomen to confirm the pulsatile mass.
C.
Handle gently and initiate immediate, rapid transport.
D.
Encourage the patient to walk to the stretcher to avoid back strain. Answer. C. Handle gently and initiate immediate, rapid transport. The concept tested is the immediate management of a suspected ruptured abdominal aortic aneurysm, AAA, which is signaled by the keyword triad of severe, tearing pain, hypotension, and a pulsatile mass. This is a catastrophic, life-threatening internal hemorrhage that is surgically correctable, but any unnecessary movement, excitement, or aggressive physical exam could cause the aneurysm to rupture completely. Therefore, the EMT's role is to minimize movement, treat for shock, and initiate the fastest possible transport to the surgical suite. Never palpate a pulsatile mass, and never delay transport for a suspected AAA. Question 29. A 55-year-old male is experiencing acute chest pain radiating to his left jaw and arm. After assisting the patient into a position of comfort and administering oxygen, if hypoxia, what medication should be administered next, assuming no contraindications?
A.
Oral glucose.
B.
Epinephrine.
C.
Aspirin.
D.
Albuterol. Answer. C. Aspirin. This question tests the essential initial field management of a patient with suspected acute coronary syndrome, ACS, highlighted by the keywords acute chest pain radiating to his left jaw and arm. Aspirin is the crucial intervention because it is an antiplatelet medication that inhibits the formation of new clots, which are typically blocking the coronary artery and causing the heart attack. Administering 162 milligrams to 324 milligrams of non-enteric-coated aspirin should be done immediately, provided the patient is not allergic and has no signs of recent bleeding. Always remember that the first-line medication for suspected cardiac-related chest pain is aspirin to prevent further clot formation. Question 30. When treating a closed, non-displaced fracture of the midshaft femur, the primary goal of splinting is to
A.
Reduce the fracture by pushing the bones back into alignment.
B.
Prevent movement of the bone ends and minimize pain.
C.
Apply traction to the entire leg to restore anatomical position.
D.
Apply a cold pack and administer oral pain medication. Answer. B. Prevent movement of the bone ends and minimize pain. This question covers the fundamental purpose of splinting for musculoskeletal trauma, focusing on the goal of stabilizing an injury. Splinting is primarily used to immobilize the bone ends and joints proximal and distal to the fracture, which prevents further soft tissue and neurovascular injury and significantly reduces the patient's pain. While traction is used for some midshaft femur fractures, it is not the primary goal of all splinting, and reducing the fracture is outside the EMT's scope of practice.
Always splint the injury in the position found unless there is clear evidence of circulatory or neurological compromise. Question 31. Airway management in a severely obese bariatric patient is frequently challenging primarily due to
A.
a smaller than average tongue that obstructs the airway,
B.
increased chest wall compliance requiring lower ventilation pressures,
C.
excess tissue in the neck and chest making visualization and chest rise difficult,
D.
inability to perform the head tilt/chin lift maneuver. Answer: C. Excess tissue in the neck and chest making visualization and chest rise difficult. This question targets the challenges of airway management in special populations, particularly bariatric patients, where the excess tissue is the main keyword. Severe obesity results in excess tissue around the neck and chest, making it difficult to achieve an adequate seal with a mask, limits the ability to visualize the airway during intubation, and restricts lung expansion, which elevates ventilation pressures. Positioning the patient in a ramped position can help align the ear and sternal notch to improve the airway axis. The key takeaway is that managing the airway of an obese patient requires specialized positioning and often multiple rescuers to achieve a good seal and adequate ventilation. Question 32. When communicating patient information over a two-way radio to the receiving hospital, the most appropriate practice is to
A.
use codes and acronyms to shorten the transmission and ensure privacy.
B.
Speak slowly, clearly, and use simple, plain English without codes.
C.
Give your diagnosis before presenting the patient's chief complaint.
D.
Use the patient's full name to confirm their identity to the nurse. Answer: B. Speak slowly, clearly, and use simple, plain English without codes. This question addresses the operational and safety standards for radio communication, emphasizing the importance of clear and unambiguous communication. Using simple, plain English ensures that the receiving hospital staff immediately understands the patient's condition and the interventions performed, avoiding confusion that acronyms or codes can introduce. Transmitting patient names violates privacy laws, HIPAA, and a diagnosis should not precede the patient's presentation. Always prioritize clarity and brevity in radio reports to ensure a safe and rapid transfer of care. Question 33. A patient is suspected of being septic, severe infection? Which vital sign finding is most concerning for the EMT and suggests the patient is progressing towards septic shock?
A.
Tachycardia and a temperature of 97.0 F, 36.1 C.
B.
Bradycardia and high blood pressure.
C.
Normal heart rate and a low-grade fever.
D.
Slow, deep respirations and a normal skin color. Answer:
A.
Tachycardia and a temperature of 97.0 F, 36.1 C. This question tests the recognition of early sepsis and septic shock, with the keyword progressing towards septic shock being the key clue, as sepsis can cause both fever and hypothermia. A fast heart rate, tachycardia, is the body's attempt to compensate for the vasodilation and increased capillary permeability caused by the infection. An abnormal temperature, either high or low, hypothermia, 97.0 F, is a classic sign of systemic infection and a dysfunctional compensatory response in sepsis, indicating a high level of stress. Recognizing the combination of a fast heart rate and temperature instability is crucial for the early identification of sepsis. Question 34. A trauma patient who sustains a severe head injury is noted to have a triad of signs: hypertension, high blood pressure, bradycardia, slow heart rate, and an altered respiratory pattern. This clinical presentation is known as
A.
Beck's triad,
B.
Cushing's triad,
C.
V/Q mismatch,
D.
neurogenic shock. Answer: B. Cushing's triad. This question focuses on recognizing a classic and critical set of signs associated with increased intracranial pressure, IC, following severe head trauma. Cushing's triad is the ominous presentation of hypertension, bradycardia, and irregular respirations, which results from the body's attempt to force blood into a compressed brain. Beck's triad, which involves hypotension, muffled heart tones, and JVD, is associated with cardiac tamponade. The presence of Cushing's triad signals an immediate, life-threatening emergency requiring rapid transport to a neurosurgical center. Always recognize that a slow heart rate combined with high blood pressure in a head injury patient is a grave sign. Question 35. A defibrillator is designed to deliver an electrical shock only to patients who are in
A.
asystole or pulseless electrical activity, PA.
B.
Ventricular fibrillation, VF, or pulseless ventricular tachycardia, PVD.
C.
Symptomatic bradycardia or supraventricular tachycardia, SVT.
D.
Respiratory arrest with a palpable pulse. Answer. B. Ventricular fibrillation, VF, or pulseless ventricular tachycardia, PVT. This final question tests the core concept of defibrillation, which is the delivery of an electrical shock to terminate certain chaotic heart rhythms. Defibrillation is only effective for two rhythms. Ventricular fibrillation, VF, a disorganized electrical chaos, and pulseless ventricular tachycardia, PVT, a very fast but ineffective rhythm. The purpose of the shock is to momentarily stop all electrical activity, allowing the heart's natural pacemaker to restart with an organized rhythm. Defibrillation is not used for asystole, PEA, or rhythms where the patient has a pulse, as it would be ineffective or harmful. Always know that you only shock a patient who is not breathing and has a heart with chaotic electrical activity.